You throughout the whole discussion, presentation today, feel free to jump in, ask questions, really have more of a dialogue. One of the things we like to do with the Knowledge Network is have a place where we can have a conversation. So don't think about it necessarily as us talking to you. We'll have plenty of information, but feel free to jump in and let's discuss. I think we're very comfortable with that. I know many of you. I think probably the most significant thing in my history with respect to this group that April failed to mention is that I worked for Denny Morrison for a while, and please don't hold that against me. So, no, we love Denny, and I only wish he was here to pick on in person. So, just to give you a little bit of history about the Knowledge Network, this started as part of a philanthropic effort that we engaged in around 2008. We had several large gifts, and the vision was to really build a national collaborative network around mental health providers who were really interested in bridging the gap between research and practice. I'd been doing this work at Centerstone for about 5 or 6 years before that. And we realized pretty early on that, one center going it alone was not a recipe for really changing the industry. We needed to kind of come together. It really reminds me of some of the questions in the other room about how do we begin to transform the system and move policy and payment reform in a way that aligns with where we all would like to go clinically. So we have to work together to do that. The core premise here is how do we shorten this research to practice gap. We all know the Institute of Medicine story, which talks about the 17-year gap between research and practice in healthcare. And this is really an effort to try to combat that. So we came together. We have worked in different ways over the years to do this. I don't know what I just apparently pressed a button that I didn't even know I had. Current membership, we have about 14 centers across the country. I'll show you that list here in a moment. In 17 states, they serve about 400,000 people a year, so it's a fairly sizable number. We have held each year biannual summits where we've brought this group together, and there's sort of the membership, and then there are a lot of other folks who've come and just really participated in the sessions and learned and engaged at that level, and that's all fine. We focused on policy, research, trying to learn from each other. It's really, in some ways, been almost a learning community, trying to take what each of us are doing well and share and spread that across Knowledge Network sites. If you look at this map, we've got stars here where each of the membership organizations are. I'll give you their names in a second. And the states that are highlighted are actually states that we have contributing to the Knowledge Network data warehouse, which is one of the most significant accomplishments of Knowledge Network over the years, and I'll share more on that too. The Knowledge Network members currently are, of course, Centerstone, the Cobb and Douglas County Community Services Board, La Frontera. You can read the list there, but typically we're looking for partners who are progressive in terms of thinking about really trying to incorporate research into their practice, trying to advance not just the clinical practice alone, but thinking about the state of knowledge as well. One of the things that really brought me, over a decade ago to Centerstone was the vision that David Goose shared with me. I remember, interviewing with him, and he said, we have an obligation as a leader in this industry, as we saw ourselves, to not just be, providing good care, but to really help begin to move the science forward. And that's not to say we're replacing what a university does, but it's to say we need to be good partners with those academics who are doing the research. And that's really the idea with the research side of Knowledge Network, which is to say, how can we band together to create a resource that can do good research? Too often research studies are done on, we all know this, they're done on populations that are very constrained, and we might be looking for somebody with a diagnosis of depression, but only between ages of 18 and 35 with no comorbid conditions, not substance abuse, no physical health conditions. And we know how rare those people actually are in our settings. Good luck finding just a few in the number of people that we see. So, my commitment, my interest is, I think it's very important that researchers are doing research in our kinds of settings because that's where people are actually receiving services, and we want that research to generalize to us ultimately. The summits have been a lot of fun. We've been able to bring in great speakers, and our focus is on bringing topics, and this is what we're doing here today. We want to bring topics to you that you might not otherwise get exposed to. Really thinking about not just sort of looking back. A lot of times I go to conferences and I say, okay, well, this is like the 10th conference on integrated care I've seen, and I think I know this. I could probably give this talk by now. It's all good, but it's sort of a rehash of the same stuff. We want to really bring you stuff that encourages you to see something in a new way, exposes you to maybe new content, new material, stuff coming down the road, but beginning to bring it to a practical application of what it might mean for you. And beyond that, even beginning to think about how do we participate in studies together or projects together that would allow us all to learn more about this new concept. So we'll learn more today about genetics and the role that might play in treatment, as well as nutrition and food this afternoon, which is also a very exciting and frankly under-discussed topic in our industry. We've been very fortunate for Knowledge Network to have many very significant high-profile partners and speakers and folks who've been working with us. Of course, a lot of university partners, Emory, of course, Vanderbilt, where I am, Chicago, Northwestern. We've also brought in I'll talk about this too, the person who set up the data infrastructure at Facebook. You can imagine that's probably a pretty considerable challenge, the amount of data they have to deal with. Came in. That's actually this individual, Jeff Hammerbacher, who is now working. He's talked about this. He personally deals with bipolar disorder and is very passionate about the issue of mental health and really bringing his sort of big data skills to help this industry, among other things. Of course, you're going to hear from Tim Ramsey and SureGene today. But we've had many good partners. We've also focused on how do we advance policy and practice. One of the things we learned very early on as we started to do collaborative research, that just doing the research really wasn't enough to change what was going on in our clinics. And we needed to be more intentional both on the policy side to say, how do we begin to move the big system levers that are going to help us create the funding mechanisms to do the things we'd like to do clinically. Again, back to the question that came up in the room next door, and that's where we've had a significant policy initiative. We worked with, of course, National Council, MHCA, all of the policy advocacy groups nationally to really advance the national policy agenda and help support that, and have had some, I think collectively we've all had some success in that realm. We've also worked to say, how can we begin to understand what it would take to actually implement evidence-based practices in clinical settings. One area that I think we've all gotten smarter about over the years is there's an area of research called implementation science, which is really it's not about necessarily new research or new findings, it's about how do you actually implement stuff once you know you need to do it. And this is a broader issue than just mental health or even healthcare. All businesses deal with this. When you're thinking about changing practice and you're implementing new policies and procedures, how do you manage the human aspect of organizational change, which is, frankly, one of the hardest things. I mean, all of you in this room do this every day. It's one of the hardest things you can possibly take on. Well, there's actually a wonderful body of science and thinking around this, frankly, mostly from outside of the social services space, mostly from the business sector, but it applies very much to our work. So we've done work, cross-site work, actually with appropriate use of clozapine and in reducing suicide use. And we've also done a collaborative research study with Telesage. It's an organization that does computerized testing to develop computerized screens for early psychosis. One of the significant accomplishments we've had is the creation of the data warehouse. The organizations, most of the organizations listed there earlier are contributing data into this warehouse, as well as other organizations that aren't even Knowledge Network members. So if you'd like to contribute to this, please feel free to talk to me or April at the end of this, and we'll work with you to figure out how to make that happen. One of the challenges we have as an industry is we don't have data to speak about the value of the work that we do. So when we would go in for those policy discussions, for the legislators, we were great at our anecdotal stories of recovery and talking about the people that we help, and that's all important, that's all good stuff. But at a certain level, the legislators, they're used to that, and they'll pat you on the back and they'll say, we're so happy to hear about the work that you're doing. I'd love to come visit, next time I'm in the community. But then, where does that get you, right? So, it's more and more about data. So with the power of this data warehouse, what we've been able to do is actually go into legislative sessions and sit down with the legislator and slice the data by district and say, in your district, here's the number of people we saw last year. Here are the conditions that they had. Here's what happened with their employment. Here's what happened with their recovery. Here's what happened with the kids in school that we saw. And really talk in detail about the impact that we have in the communities in a very specific, very targeted way to their language. And I have to tell you, after going up and talking to legislators for many years, it's a different conversation when you take data with you than when you don't. Again, it's a very nice conversation, pat you on the back, love to see you as a constituent when you go up and tell them nice heartwarming stories. When we took data up there, they're like, this is amazing. How can we help you with where you're wanting to go? I mean, that's a very different kind of conversation that we have. This is, to my knowledge, the largest warehouse of community mental health data that exists in the U.S. Of course, other countries with nationalized systems have larger sets of data. And of course, there are managed care data sets that are larger. But in terms of our data, community mental health data, this is the largest store we have. It's begun to get a lot of interest from the national research community. Tom Insel within IMH and other folks we've been talking to about how do we really begin to leverage this information to promote mental health services research, to understand what works, what doesn't work. One of the things that we're beginning to discover as we look at this data that will probably not come as a terrible shock to the people in this room is that even though we all are sort of here and kind of in the same business, we do it all very differently. So you could even look at two centers that are in maybe the same state. They have the same basic funding streams. They serve basically the same demographic. They might be 30 miles apart, and you look at their profile of services that they deliver based on a given diagnosis, it's completely different. So it gets to the focused path tree discussion that we were having, again, an hour ago, about why do those differences exist and what's really best for the patient. We as a field, frankly, don't know that. We don't know what's best. So we do it all differently. So we put together this advisory committee of leading mental health services researchers, a big data sort of guru, and some other folks, health economists. Of course, you probably know Ben Druss, tremendous mental health services researcher, probably one of the best in the country. And other folks who are really helping us develop a research agenda around how do we, now that we have this data store, how do we get the most out of it? To advance research and really make meaningful policy statements about where the industry needs to go, and use that to advance our cause. Where are we going ahead before we get into the meat of our session today? We have a monthly conference call. If you're interested in participating or learning more about any of this, please feel free to contact April, contact me. Be happy to get you connected into this, share more information. We just received funding actually a couple months ago from Dorothy Batten. She's the daughter of Frank Batten, who founded the Weather Channel, to launch an initiative around using apps to promote wellness and positive mental health in kids. So if you're interested in that topic, again, come talk to us. We'd love to have partners and folks that would like to collaborate on that. It's a very exciting national initiative that she started. We're going to be at the mHealth Summit in December 2014. We're thinking now as in terms of future growth for Knowledge Network. We've done a lot of conference-type activities. We're thinking about doing more stuff like this, where we partner with existing conferences. Frankly, we don't like doing all the logistics of a conference. It's a lot of travel for people to come out for one day. So we felt there was some real synergy with mhca, and we're excited about this partnership. We're also thinking about how do we leverage virtual networks. I mean, we can communicate differently now than we could even 6 or 7 years ago, and we want to think more about how we use those tools. There are opportunities for us to do cross-site studies. Tim is going to share one of those today about genetics. There's incredible power in coming together to create a massive pool for research that draws the interest of industry and researchers alike. So we'll have a discussion about that. We're also, of course, as always, looking for more philanthropy to support this effort. So with that, I'll stop the overview there. I'd be happy to answer any questions you have, and then we'll move on with our... Any questions? Good. So I'd like to introduce Tim Ramsey. He's the Vice President of Product Development for SureGene. Today he's going to be speaking about leveraging pharmacogenetic testing to improve consumer outcomes. He focuses on discovering novel biomarkers of antipsychotic response and translating those discoveries into commercial products, as well as managing SureGene's external partnerships. He's the primary inventor of several SureGene patents. He designed the SureGene test for antipsychotic and antidepressant response, which he's going to talk about, I believe, some today. He founded SureGene with Dr. Mark Brennan in 2004. Prior to joining SureGene, he worked at Eli Lilly in the Neuroscience Discovery Group, where he was the interface between finance, marketing, and new product development and the R&D group. So he has a long history of doing this kind of work and bringing innovations to market. He received his MBA from the University of Chicago and his master's in biochemistry and molecular biology from the University of Louisville School of Medicine. So today he's going to talk about the potential of drug response genetic testing to enhance not only patient outcomes but also organizational level response metrics, performance metrics. He'll provide an overview of what this is. He'll discuss the unique challenges that we have in behavioral health with this kind of testing, share some data showing the impact of this testing in routine practice, and discuss how the electronic health record can really facilitate the execution of organizational testing in this way. I will say when I first started this work at Centerstone a little bit more than a decade ago, I thought that 10 years in the future we would have as a routine part of care, we'd have genetic testing. Everybody would come in the door. We'd have testing. We would use that to help inform the medication decisions that we made. It's been, as we all know, a much harder and slower road than we thought to get there. But I think we are on the verge of that, and I think it's a significant breakthrough for the people we serve in terms of getting treatments right the first time instead of, the trial and error methodology that we often find ourselves with in practice. So, Tim, I appreciate you coming today.
Where's the pointer?
And I'll turn it over to you.
Well, thanks, Tom.
So after he speaks, we'll have a brief Q&A session and discussion with questions as well.
I thank Tom and April for inviting me to talk to you guys, and I appreciate you listening to what I have to say. And a lot of the themes that Tom was talking about, the goals of the knowledge network, actually line up with the things we're trying to do and trying to improve not only patient or client outcomes, but also organizational outcomes, because behavioral health is hard. I'm sure everyone in this audience knows that. A little bit, before I get started, a little bit about the history of SureGene. So there are a lot of players in the genetic testing space these days. What makes us unique is that we are a research-driven organization. We came out of a long-standing research project funded by the National Institute of Mental Health from the early 90s, looking at the genetics of personality traits in the normal population. From there, we moved into psychosis, because we saw some very interesting links between personality traits in the normal population and psychosis. And from there, we actually moved on again to the genetics of response to antipsychotics and other behavioral health medication. As a company, we've been around since 2004, so 10 years back in May. And again, one thing that makes us unique and different from the other players in the space is we have a focus towards efficacy and outcomes. So the other players tend to be more side effect oriented. We do that as well, but our original research, the things we do different and novel, are all around outcomes and efficacy. So as I was saying, behavioral health is very hard. I'm sure I'm preaching to the choir here, But you have a situation where you have a disease or diseases they're very prevalent. Unfortunately, there's still tremendous unmet medical need. We're not at a point where we can say, okay, here's what you have, take this medicine, 3 weeks later, you're done. That's not the case. Treatment variability is a tremendous problem, as I'm sure you're all aware. The first drug isn't likely to work. The second drug may not work. Maybe 3 drugs, 4 drugs, 5 drugs, and then also concomitant medications. I've spoken to clients that are on 10, 15 medications at a single time. So it's a very challenging realm in which to operate. And unfortunately for you guys, you don't have a lot of information to do anything about it. You're in a situation where you have each provider tends to have their own favorites they like to do, but outside of that, their personal experience, all they really have is the drug company marketing materials, or more likely a strict formulary they have to follow from a payer. And I'm going to talk about that in a minute because that formulary isn't good is not good at all for the clients. Compounding this problem is it's not like you have 1 or 2 antipsychotics or even one class of antipsychotics or antidepressants. You have multiple classes. Each class has multiple drugs. So you have this huge deluge of information of trying to figure out which drug fits with which patient. Genetic testing can help with that problem. It doesn't eliminate it, but it can try to simplify it and give you a little advance notice or impetus moving forward. Additionally, behavioral health often comes concomitant with other medication or other diseases and diagnosis. These slides are from the Medicare population, and 25% of the people have a mental health disorder at some point in their life. Probably at any given time, 15 or more, 20% have an active issue. In the Medicare population, 70% of the people with a mental health disorder have a concomitant other disorder. And what happens is when you have these multiple disorders, you get a compounding effect in terms of the impact on the patient, because each of them are contributing to the challenges. So behavioral health problems can contribute to problems of management of the disease state. And what happens is when you have this overlap is 2 things. One, mortality goes up. So these numbers right here that you see, these are multipliers. Let's say you have any given disease state, cardiovascular, diabetes, doesn't matter. There's a mortality rate associated with that. If you stack on one of these mental health disorders, you get a multiplier effect. It can be as high as 4-fold increase in the mortality because you have 2 separate things or multiple things going on at once that are compounding the challenge of treating that patient. So you can see if you can manage the behavioral health component, any incremental change you make there will reduce this all-cause mortality number. And obviously, this mortality and the other issues translates into dollars, big dollars. So these, and again, in the Medicare population, these are very, very common disease. Most people in the Medicare population have 1 or more of these. And you're looking at maybe $10,000 a year to treat them. You stack on top of that a mental health disorder, and you get a tripling or a doubling of the cost. So it's not an additive cost. It's not the cost of seeing a psychiatrist. It's not the cost of the other medications added on. It's actually a synergistic and a multiplier effect. So you're looking at some very dramatic cost numbers here for treating people with concomitant disorders. So this is, I think this is being taped, so the references are down here for each of these. But this is the extra money that has been attributed to these concomitant disorders that are going out of the systems. And just in the Medicare market, you're looking at $50 to $100 billion per year. All in, if you include everybody, it's $130 to $350 billion a year of extra cost that are associated with concomitant disorders. So you can see that even making a very tiny reduction in the impact has really, really strong change. So let's take this lowest number here for Medicare, $50 billion a year. If we can make a 10% improvement of that, that's $5 billion. That's enough to pay for every single person on Medicare before it's indicated to be genetically tested in that 1 year. So you can see that there's potential for not only cost reductions, but actual cost savings all in. And that's on top of the improved outcomes. So one way you can do that is personalized medicine, or as it's becoming known these days, is precision medicine. The way we do it is through the use of a genetic test that will identify, how the patient is likely to metabolize the drug, as well as which drugs they're more likely to respond to. STAR is our branded version of it. It's the SureGene test for antipsychotic and antidepressant response. And again, it's a collection of, I think at this point, 12 different individual genetic tests that comes in as an organized report. And I'll show you a copy of some of the output in just a minute. Now, one question is always, well, when should you use it? And so at a high level, everybody should have this in their medical records from birth, I think, because it's so impactful. But from a practical, cost-effective standpoint, it's basically any time you need to try a new medication. The ideal time is the initial visit. When you're making the initial medication decision, that's the optimal time. But anytime you want to switch because of, for a dose or for tolerability reasons or efficacy reasons, that's another great time. And then obviously if you had a failure, a hospitalization or a crisis, then that's really a time when you should consider it. Obviously we don't want to mess with success. So if you have a stable patient, while the test will have useful information, it's not something practical, because I would never advocate someone changing something that's working based on the reports of our test. It's very simple. It's a cheek swab. Have you ever seen CSI or any of these procedural shows? A giant Q-tip in the mouth a couple times, goes in the envelope. You call the UPS guy. He swings by and picks it up. And it's quick and very easy. And several days later, you're going to get a test report back. So for the next couple of minutes, I'm going to give you a sort of a brief overview of what everybody does. And then I'm going to talk about what we do different. And then I'll follow that with some outcomes data. So everybody, you probably may have heard this if you've heard anything about genetic testing, these metabolism genes, or you heard these called cytochrome P450s, these CYPs, the 2D6. What does that mean? Well, those are liver enzymes. And these are the things that in your body, when you take in a medicine, they're going to metabolize it, break it down, and help you, get rid of it. And the dosing guidelines you get from Big Pharma is based on the average. How does that work for a prototypical average person? Thing is, nobody's average. Everybody's unique. And for each drug, it goes through certain pathways. And that pathway may work perfectly in an individual. It may be completely broken, or it may be, ultra fast. It may go much faster than typical. And that can really impact the physical disposition of the drug itself, but then leads to changes in safety and tolerability and efficacy. And you can see if you're a poor metabolizer, the drug builds up in your system, your side effect profile increases. If you're an ultra-rapid, you never get enough drug, and it just doesn't work. This is complicated. But I try to make it very simple in some graphs. You have a nice little Goldilocks region here where you have your therapeutic window, where everything is okay. Your side effects are hopefully tolerable. Obviously, I'd like it to be none, but behavioral health meds have lots of side effects. Down here, not enough drug. Up here, too much drug makes people have more side effects. Well, what happens in a poor metabolizer, over time, you're giving your doses, or this is a normal person, sorry. You give your doses, you're right here in this Goldilocks region, everything is good. You're doing it as the manufacturer recommends, things work great, hopefully. But if you have a poor metabolizer, well, all of a sudden, here, a few days down the road, this patient, if you look at their blood levels, it's as if you gave them a much higher dose, possibly a toxic dose of the drugs, because some of the drugs that we use have very narrow dosing windows. Now, we'll talk about one in particular in just a second. On the other side, you can see if you're an ultra-rapid. Okay, I was wondering if I was in a different room. That's okay. So I'll tell you the story, which I think was on the previous slide, of the primary example of why this is really important. So in this audience, I'm sure you use a lot of risperidone or Risperdal. And in fact, a lot of formularies, you must fail Risperdal before you try another antipsychotic. Here's the thing. 45% of the people, it's unsafe to give them Risperdal because they are an altered metabolism of a liver enzyme called 2D6. So 45% of our test reports come back with avoid or use with extreme caution with Risperdal. Not saying you can't use it, but it's very difficult. You probably want to do therapeutic blood monitoring. So if you want to avoid that, then you would select something else. And yet this is the thing that many formulas say you must do this. Yet 45% of the time, it's not safe. Either they're burning through it too fast and it's not going to work, or they're poor or intermediate metabolizers, their blood levels are higher. And risperidone has a very narrow therapeutic window. 5 milligrams a day is a good dose for as an antipsychotic. But by 8 or 10, you're starting to get EPS and all these other symptoms really start to go through the roof. And it's above that, then it's really unsafe. And this is absolutely what can happen for up to 45% of your population. Okay, so everybody does this. I think we try to do a better job of communicating things like the avoids than perhaps our competitors, because we feel it's more important to give you more information. We also do original research, one of which, one of the genes that I discovered the test for is something called SULT4A1. This is not a science talk. I won't bore you with all the biochemistry behind it, but it's basically an enzyme in the brain that impacts a lot of really important things for mental health. And it also impacts response to olanzapine. So the data you see here is from Caden. If you're not familiar with this, a large federally funded study by the NIMH in the early 2000s that looked at a number of antipsychotics. And as expected, about 25% of the people on any given drug had a clinically significant response, and that's measured by a scale of symptoms. But you can see there's an obvious outlier here. Instead of 1 in 4 having a good response, 3 out of 4 had a good response. And that was the 25% or so of people who had this particular version of this gene and were treated with olanzapine. So there's two important things here. One is obviously this group really should be on olanzapine. But the other is this group probably shouldn't. And so for those of you who've been familiar with olanzapine or Zyprexa, in the early 2000s, this was the dominant choice, the preferred choice as an antipsychotic because it worked. Outside of clozapine, it worked by far better than anything else. So people used a lot of it. Over time, there's been a real pressure and move away from it, first for cost reasons and second for side effect profile. It is now not nearly used as much as it used to be. What happens is this marker and another marker can explain a lot of this preferential advantage. So there's certain people that do phenomenally well, or highly likely to do well. But here, in this, this is 3/4 of the people, olanzapine is still a good drug, but now it's a me too drug. And now the side effect profile would really dominate the discussion, I think, in terms of whether or not you used it. So, that's a clinical scale in a controlled setting. What about a real-world outcome? Well, hospitalizations, I'm sure you're familiar with. A lot of your clients have been to the hospital, and once they go, they tend to come back. So schizophrenia, it's about 20% of people go in to the hospital at least once in a given year. Bipolar is probably 17, 18%. Then once they go, the odds of them coming back within a year are 1 in 2. I've talked to some facilities where it's 35, 40% within 30 days are back for any number of reasons. But it's a real challenge of keeping people, A, from going to the hospital in the first place, and B, for returning to the hospital. So the same marker, when you look at hospitalizations, and these are people that had a prior history of hospitalization, and you can see they're right around what you'd expect to see, right around 1 in 2. 50% of them came back within 1 year. But the SULT4A1 people who had olanzapine and quetiapine, which actually is virtually identical to olanzapine from a chemical standpoint, that reduction is an 80% overall reduction down. And the overall rate for people even not hospitalized was 1%, from 20% down to 1%. So you have dramatic shifts in the rate of hospitalization. And as we all know, a bulk of the cost in mental health lies in hospitalizations, ER visits, and things that are very expensive each time. The nice thing, I'm not going to spend much time about this, is that the data seems to suggest that you may be able to have your cake and eat it too. So the side effect profile is actually better in the people that do better in this narrow group, which is a little bit contrary to what people expected to see. So that's very exciting. If that continues to help, that will actually further change the population. We have a new marker, which again I'm going to avoid the science. This was just published in Schizophrenia Research last month, and here's the short and dirty version of it. Is what does this mean for drug selection? So there are 4 types of people with regard to this particular gene. This gene is involved in insulin metabolism and release in the gut, but it also does some very interesting things in the brain with appetite, satiety, and pleasure, and these sorts of things. So a lot of interesting things going on. We can divide people into 1 of 4 buckets, and each bucket has a differential response profile for a set of drugs. So if we're look at this group, there's a group, olanzapine does really well, and other medium to high weight gain drugs do well. The low weight gain drugs do awful. In fact, these people actually, on average, get worse when you give them the drug. So there's an interesting link here between weight gain and efficacy. Then you have a large group here in the middle that turns out the best drug for them is this older generic atypical perfenazine. And lots of drugs you would avoid. So no clozapine, no olanzapine, no quetiapine, just because they don't do as well. Back to risperidone, a thing you must try. There are 20% of the people that will likely get worse when you give them this drug. So you got 20% that are likely to do worse, 45% for whom it's probably unsafe, and now all of a sudden you have a situation where, call it 60, 65% of the people who you must give risperidone, you're actually giving them a bad drug. It's very challenging to sort of change the practice, and obviously the payers haven't caught up with this, because otherwise they would say, no, do it. They wouldn't have the rules they do, but they're cost-focused. Generic risperidone is relatively inexpensive. So this is the way you could actually change your practice. You could also think you could institute very simple recommendations for, that could be embedded into your EHR that say, okay, for this patient, maybe we don't want to try risperidone. Maybe we want to reprioritize a different drug, whether it's olanzapine or it's quetiapine or what have you. It could be a big change. This is what we try to do in our report. So this is a copy of, we give you an individual gene-based report. Some people like that. This is a report that's organized by drug. You can say for olanzapine, we recommend it for this person because they're likely to have a good outcome. No SSRIs. So, probably your depression protocol says try generic SSRI. Well, 3 out of 4 people, we're going to say don't do it. Go to a different class, whether it's SNRIs or tricycles or MRIs, or probably even bupropion would be even better. This person's got a folate metabolism problem, so L-methylfolate might be a great thing to do for them to augment efficacy. Right here you get risperidone, avoid. Some other ones where you say, okay, here is a good dose recommendation. And then we have a lot of medications where the science isn't there to say, hey, you should give them 50%, but it's definitely there to say, be careful. You might want to decrease your dose, titrate a little slower, have a lower max, and observe your patient a little more carefully. And so again, even if you want to use the drug over here, that's fine, but now you have a little bit of information of, well, I shouldn't rush the dose for this patient. Same would apply for antidepressants, and then for a lot of other medications, stimulants, anxiolytics, smooth stabilizers, that sort of thing. So what does that mean in the real world? So we've worked with a neuropsychiatric clinic. They've been one of our early adopters, and we had a year's worth of data for their whole practice, and we looked at people who were tested, people who weren't tested. The doctor was making the decision. We had no input. He tested whoever he wanted to. And we said, well, was there a difference? What does this look like? And the nice thing, in contrast to what some of our competitors, back to your comment, Tom, about narrow definitions, this was all comers. And you can see the breadth of diagnosis that were here. And most of them actually had multiple diagnoses, which is why things add up to greater than 1 here. But one of the interesting things is nearly 2/3 of them were primarily there for neurological reasons. So whether it was traumatic brain injury or it was Parkinson's or other things, but they also had concomitant symptoms that were being treated with antipsychotics, antidepressants, that sort of thing. This is a real-world look at a clinic, broad definition of what's an appropriate patient. And the nice thing, as Tom was saying, there was data there. And they routinely use a scale called the neuropsych questionnaire short form. But it gave information across 12 different dimensions of illness. What was really interesting is the tested group did far better on 8 of the 12 dimensions: aggression, anxiety, depression, impulsive behavior, mood instability, panic, and suicide. And it turns out all of those symptoms are treated by drugs for which we're able to give useful information. There are 4 symptom dimensions where there was no difference. So fatigue, memory, pain, sleep. Excuse me, actually there's 5 there. Then what's interesting about those, our test report doesn't have much to say about those particular symptoms. So the symptoms for which we did give information, big difference. I mean, we're talking a tremendous difference in outcome. Here, no difference. So it's sort of an internal validation, even though it was sort of a real-world study, and you have all the issues concomitant with being a real-world study, it came out exactly as one would hope. It was very targeted. Only the symptoms for which we could help showed an impact. So it wasn't an artifact of just being tested or the patients being selected. Well, how often did this add value? So we had frequencies of the various genetic results from that, and I had access to a large national EHR of about 5 million lives that could give me the prescription frequencies, the top 10 drugs in each of these various classes. And I could do a little math and come up with some numbers of how often was a prescription potentially being made that was suboptimal. Yeah. So in SSRIs, 90% of prescriptions out there in the world are probably suboptimal. Between the metabolic piece and serotonin transporter piece, 9 out of 10 times, a test would have given you useful information if you wanted to prescribe an SSRI. For SNRIs, things like Cymbalta or venlafaxine, that's about half. About half the prescriptions would have benefited from the genetic test. For the older drugs, depending on the drug, it ranges from 42% up to 80% of the time that you prescribe the tricyclic, you could have had more information and made a better decision had you had the test. In the antipsychotics, obviously I think that olanzapine, you would always want to know. The older version of the test that was used here was about 55% for aripiprazole, risperidone, and the lower amount for quetiapine. But with the new version, has the new marker on it. Virtually every time you write a prescription for one of the most commonly used antipsychotics, you could have made a more informed decision. Now, you may have made the optimal decision to begin with, but what this is you made it in the absence of information that could have helped you make a better information. So this translates to cost savings. So there's a lot of research in Europe because they have a national health service and they're motivated to figure these things out. But simple genetic testing, people seriously, not our proprietary things, but just the metabolism component, estimated about $5,000 per year. And if you do a little financial analysis of that, that turns into about $50,000 to $100,000 lifetime value. Third-party estimates from large catchment areas of costs for hospitalization. So we use those third-party estimates of cost, and then we applied our delta and reduction of hospitalization. So basically for every patient you test. So I have a slide that often shows that people that their first visit, it costs about $8,000 to $10,000 a year to treat. If they've had a previous hospitalization, they go back. It doesn't go up a little bit. It goes from 8 to 10 to 40 or 50. So it's the repeat offenders, or it's the right word, the repeat visits that really drive up the expense. And I have the white paper around this that I could send anybody that would care to see that. So how does this make a difference? Well, there's a challenge if you got lots of different drugs and you don't know a lot about them to make a decision. What we can do is say, well, 90% of the time, you're going to get information about an SSRI. It allows the physician or the provider to make a more informed decision. It is not a silver bullet. It's not a magic bullet. But what it does is it empowers the doctor to make a better decision. Again, with this unmet medical need, high treatment variability, how's this going to work? Well, we are able to identify subgroups of patients that preferentially respond or don't respond to a given drug. The idea is you can improve the standard of care for a given group of people. And the point I made earlier, risperidone, which is usual first-line antipsychotic, nearly 75% of the time you're going to come back with saying do something different than what your payer may be mandating you do currently. Same along with SSRIs. 90% of the time, one can make an argument from this that maybe you just don't use these guys at all anymore, or you deprioritize them. And both research studies and real-world outcomes show that testing improves patient lives. So what can we do about it? So back to Tom's point of collaborations and working together, we are working with other partners, testing partners, to conduct a large, very large trial in the Medicare population. Medicare is very interested in this topic because Medicare is a growing segment of the population. They have enormous spend dedicated to this category, and they want to find out, is it cost effective for them to implement routine genetic testing? So we're recruiting over 250,000 patients. This study's been approved by the Medicare contractor at that number. And it's focused both on patient outcomes as well as physician behaviors, because all the science in the world doesn't mean anything if we can't help doctors do something different. So we actually have to be implemented. So that's one of the things the study is measuring, is that does the science translate into actual practice inside the clinic? And for targeted areas, we're going to layer another study on top of that that does a deeper dive on efficacy and hopefully health economic research. This is why we're working with Tom and Centerstone and the organization in this room have the opportunity to help us and make a real difference in policy and the treatment broadly. That's all I have. I think we're ready for some questions, and Tom and I are going to have a short Q&A, I believe.
Good. So any questions at this point for Tim, Mary?
Yes. Mm-hmm. That's a great question. So we have a number of different things. So we work with contract sales organizations to do the marketing. Those guys are trained. They do a lot of in-services. They train the doctors where appropriate, where it's a good value. I will actually go and do the lunch or the dinner and do an educational session. I do talks like this. One thing we offer that seems to be very useful is it's new to a lot of physicians, and so I'll say, hey, you can set up a time to discuss the first couple of results. You come in and we'll walk through how you would analyze that. But it's a great point. It's one where we can obviously do much better in the training. So so that's of course. I wondered the same thing. I wish I knew the answer to it. So one of the reasons in the Medicare population is why the study was approved is they want to answer that question once and for all. So is it cost effective? Does it improve patient outcomes? I would say that answer was proven 10 years ago, but Medicare is not there yet. That's why they're doing this study. So Medicare, in the context of the study, is paying for it. Private insurers are all over the place. Even insurers that used to be... This is a Medicare. This study has been approved and sanctioned by Medicare. So one of the regional MACs, this is under their auspices.
So this is actually a perfect example, in my view, of the kind of study that fits Knowledge Network. So Medicare is funding this study, 280,000 people they want to enroll nationally. And you correct me if I'm mistaken, if I'm misstate any facts, but what they're actually looking at here is the outcome. Is they're wanting to see, does this actually change the decision making, the provider behavior? They're not even looking at clinical outcomes at this point as a primary.
Not as a primary, no. It's can you change physician behavior?
Which
yeah,
it is sort of our life, right? But the question is, so Medicare, you can figure out. It doesn't take much to figure out what's going on in their mind. They're saying, well, does it make sense for us to pay for this as part of routine practice going forward? And the first question is, does it even change practice? And it would make sense for us. We don't want this study to happen, in environments that completely ignore, the community mental health, and happen in academic settings and so forth that don't look like us. So, this is an opportunity to inform policy going forward based on the results of this research.
So, Tom, how much does the test cost?
So, it's actually a very challenging question answered for the following reason. Each insurer has their own thing they do. So we build them a number that's meant to facilitate, fit into the system. There's a number that we would charge if everybody paid on time in an appropriate manner. It doesn't work that way. And if you bill them X dollars, they're going to give you about 30% of X. So there's the amount we bill, it can be a fairly expensive test, but with the expectation that if we're lucky, we'll get 30% of what we bill. For a private person, we try to limit the out-of-pocket maximum they have. It's an income-based sliding scale. So it never costs the facility anything or the physician anything. At the patient level, if they're in a community health center and they don't have much income, I think it's like $10 or $15 is the maximum out-of-pocket. If you make a lot of money, $200,000 plus, I think the number is $299. Yes. Sometimes they pay 30% of it. No. So there's a couple of pieces there. Back to why it's challenging. So most insurance companies say if you take our payment, you must use that as our assessment. So let's say they reimburse $500. That's their thing. That's what the bill becomes, is $500. And then they give you, say, 35% or $350 after co-pays and whatever. Then the only thing left would be $150 for the patient. And then that $150 could be adjusted based on the patient income. Again, it's really irrational to me the way you have to game the system. The insurers, I'm sure you guys are familiar with it. If you knew you got paid 100% of the time, you could charge a fair market value for your services. But the way you do, you bill it, and they automatically get you a haircut because they think you're charging too much. It's sort of a cycle. And until we have data, like the study, and we have a metric set, say, by Medicare, that's what we're going to be dealing with.
So back to the study, though. So it's a Medicare study, and again, you've got all the facts on this. So it's the patients who are eligible for it are Medicare. We looked at Centerstone. We looked at our own data, thinking about the opportunity to enroll in this. It's about 10% of the people we see, it looks like, would be eligible for this, just in our in our setting. Obviously that doesn't address the needs of the other 90%, but I view this as an opportunity. We see this as a coming trend in our industry that we need to be preparing for and figuring out how do we begin to incorporate this into our practice, how do we sort of accelerate our learning curve as an organization about dealing with this kind of technology in our setting. And in this case, it doesn't pay for everybody, that might be perfect, but at least pays for 10%, which is, for most of us, a pretty significant number of people and a pretty significant enterprise to learn.
Yes, a follow-up.
There was a question back
by
here.
Medicare, it also means not only people Medicare by age, but by disability as well.
That is robust and put it in people's hands. So I guess that's where the question comes from. I see what you're doing with Medicare, but have you thought, or has Centerstone Group thought, of a crisp phase 3 prospective 2-on trial that actually looks at improvement in outcomes, efficacy, and financial improvements for and invest what it costs, maybe make that too much ask, but invest what it costs to publish it up for dissemination, take it out from like a pharmaceutical company and bring it out. And we can be able to use the increasing value of data in the marketplace.
Yeah, so I would love to do that. If you took the entire pharmacogenetic industry as a whole, every company out there, put us all together, we couldn't afford to do that study. It's too expensive. So you're talking $50 million or something to do that study. Yeah. Yeah.
It's pretty.
Yeah. No, I agree with you. The problem is so for me personally, there is no such thing as schizophrenia, bipolar. Those are labels; they're not diseases. At the genetic level, at the disease label, it's really a collection of a couple hundred orphan genetic diseases that present in certain manners, and given how a patient presents. So the challenge there is how you define the patient population. Yeah, so we did that. It was because we could have access to the data. Yeah. Yeah.
I love that concept. I think we have a tremendous opportunity if we come together to provide a perfect population for that kind of trial. I think all we would need is the research partners who bring sort of the methodology and the statistical and all the funding connections to get the money for that kind of trial. Yeah.
Well, certainly what we're doing with this study, so we have the large population that we have funding for. One of the things we're working with Tom and Centerstone is in targeted areas, what can we do on top of that to leverage that infrastructure to get more information? So I don't know if we could do a multi-arm study in that case, but we could certainly target it for certain specialties and groups that have specific research interests. Yeah. Right. So that's exactly what. Yeah. Absolutely.
Interesting.
Yeah. Okay. Yeah. So there's a reason they're doing it. They're doing it. They're doing it for the data. They're losing money every time. Or it's an expense item for them, and they're doing it for a reason. If everyone would get together and say we should do it for everybody, we could bring the price point down, not to $99, but sub $500, and the payer should be able to pay for it. One of the goals of the study is to obviously help do that. And some payers are on board. I mean, United Healthcare does well. Humana does well. For our experience has been, it worked. You know, those are the people that are on board. They're paying, and then what's challenging for the companies like us is the insurers tell us what we have to bill the patient. Or they say, if you take our money, this is what you must do. Now we don't collect. We don't send anybody to collections, and we have a income-based adjustment. But those are the rules that we have to live by, and it's unfortunate. No question? Yeah. So your genes are what they are. We will probably never do pediatric research just because that has extra burdens and concerns. But I have 2 young boys. I would test them immediately if there was a reason. So there shouldn't be any difference other than the usual differences you would see between adolescents or children and adults. The genes are what they are. So if they're a poor metabolizer, they're going to be a poor metabolizer their whole life. They're adult, it's going to be the same thing. We do actually have a lot of kids that use it. It's good for stimulants. It's not awesome for stimulants just because it doesn't, there's not a lot of information available about methylphenidate, which is most people use for amphetamines and for other things. It's quite good. But for Ritalin, it's of limited value. There is some value around one of the genes I didn't talk about, but it's modest. But if you're doing anything else, any sort of other things for agitation or aggression, those medications, I know risperidone used a lot in kids. 45% of kids shouldn't be getting it. So I agree with you. I would also argue that happened 10 years ago. So the things I'm saying about risperidone are in the label from the FDA. So, I mean, and yeah. Yes, I understand. Right. Yeah. So what I didn't show is it's never enough for us either. We have alternative things. We do discovery there because it was large and it was available, but we replicate elsewhere. Yeah. Yeah, absolutely. The big pharmas aren't there, although we have a paper in we have a paper under review with a major pharma that'll be very interesting when it comes out. We did a collaboration with an international pharmaceutical company that's under review right now. So, yes.
One thing we've actually been talking about with respect to this, with respect to the Medicare trial, and I think the $50 million trial is another,
It's the multi-arm, really controlled, tightly. Right. So you have to do one for every drug. That's the first thing you're going to have to do. And yeah. Absolutely, I 100% agree. One of the things that Tom and I in April, the team at Centerstone was meeting with them last week was, how can we do that? How can we leverage IT infrastructure? What things can we do to bring these marginal costs down, to reduce the impact of productivity at the physician level? That was a great concern of Tom and Karen, his medical director, of what does this happen to the, how can we minimize the impact of the physician on their daily life? These guys are super busy, and your providers have no time. And so how can we leverage IT, the knowledge at work, the data warehouse, and as you were about to say, a centralized consenting process that takes a lot of the burden off the individual site so they can just practice medicine and help their patients.
Really interesting. Yeah, I think there's an opportunity. One thing we've been thinking about is how do we, to your point about making it cheaper, is one of the great expenses of a trial like this that's this big and could cover this many organizations is, how do you build the infrastructure that you need at each location that it could potentially be, so you have a consent process and you have the swabbing and the data collection and there are some opportunities, I think, to sort of build a centralized machine to say, do that consent, you could do it remotely and so forth, leverage the technology, leverage the data the capture platforms and so forth, to make it cheaper, more efficient, and minimize the impact on clinician productivity and client access. I mean, what we've seen in our setting a lot of time is, for everyone, I think productivity is a significant concern, and even if you could get, the financial payment to offset the productivity loss, it doesn't mean you still don't have people knocking on your door seeking help. So you can't, even if you can offset that productivity expense, you still have an access problem that you're creating if you're seeing less people in the time that you have. So. Yeah.
All you're really doing is giving them the test, which if you can afford it, you buy the bill. Give them a test. If you go ahead and try it, let's see what the outcome is.
I think that's what this Medicare study does.
Yeah, so it's obviously no cost to the physician or the facilities and support for the logistics.
You want to talk about that?
Well, sorry. Absolutely. It's one of the reasons. We're just getting started with the Knowledge Network, and we've been discussing, it can either be through your institution alone or through the central process that we're setting up with Tom's group.
So we're in the process. We have not started at Centerstone. We've just been in a discussion about what that might look like. We've been talking to our, starting the discussion with our medical staff about their level of interest, and we wouldn't go forward on this without their, support and leadership on it. So we're figuring that out now. Part of the reason I thought it would be helpful to bring to this group now is to say, are there other folks who would be interested in sort of partnering with us on that journey? I think we can figure we're going to face a lot of the same kinds of challenges, and that's the spirit of Knowledge Network, is figuring those things out together. I think even the ideas in this room this morning about some of the opportunities in California, leveraging some of the technology platforms, how do we work with physicians, are really key points that would help all of us to be working together on. So I would encourage you, if you're interested in this, again, contact April, contact me, contact Tim, and we'll sort of carry the discussion from there, depending on the level of interest.
Yes.
Personally, I just think from a business standpoint, I mean, if you just think about separating your organization from the pack, this is clearly coming. You know, this technology is clearly coming. You know, it's maybe not ready for prime time in every setting. It's not, not everybody's paying for it. All the infrastructure that makes it all work isn't fully in place. But I think setting yourself up to be a leader in this area really differentiates you from your competitors in your local space who probably are doing nothing in this. So, the ability to say we offer this, if you've got a really tough case, that we're the place to come. That's who we all want to be, right?
Organizations that are doing this, do they see this as human subject research?
So the big study itself has been approved by Copernicus Western IRB, and there's a consent form around it. It is a relatively benign consent form. So because it's non-interventional, it avoids a lot of the. We're not saying you must take this drug or you must do this. We're saying here is information. We hope it helps you make a better decision. And the doc uses it or doesn't. They use their clinical judgment as what to do for their patient. They very well we could say, don't use risperidone, which will say a lot. The doctor says, I think this patient really needs to be on risperidone. That's okay. That's one of the outcomes we're measuring. And because of that, the barrier is lower. And talking about the comparator arms, if you have a practice that has good AHR with outcomes measures, that data doesn't even need to be consented because you can aggregate it at the practice level, completely de-identified, and it's aggregate data. That doesn't need to be consented. Yeah. Right. Yeah.
Yeah.
So we give them wiggle room. We say, or use with extreme caution. So, because I would never tell a doctor not to use something he wants to use. But I will say is, if you want to do it, be careful. And then from a practical standpoint, the practical thing is to avoid. All right.
What about high-tech requirements in terms of generic data collection?
So for the broad study, there is no data, high-tech requirements. It's, can you get the swab? There's electronic data capture form. It's basically 3 case reports you fill out electronically, in any computer. But that's web-based. But that's it. Now, for folks in the knowledge network where you have good EHR systems, then we will work with you to get the data out into the study database and try to minimize the impact on your IT staff. But that would be for targeted things. So for the big study, there is no requirement, other than somebody can have a desktop or a tablet that can access the web-based case report that you're using for outcomes. So the big study is changing physician behavior. If they change the medication, so to qualify, they have to have an adverse event or a treatment failure on a study drug in the past 90 days. But virtually every Medicare patient in the paper is going to meet that criteria because there are so many drugs. I mean, even things like nausea or sleepiness is sufficient to trigger eligibility. So most Medicare patients will be eligible. But it's sorry, what was that?
So the primary outcome
The primary outcome is a medication change made from a conflicting drug to either a different dose of the conflicting drug or a different drug. That's the primary outcome.
So you're not looking for index patients getting their first.
No. So for the study, it's 90 days. 90 days medication history. So it's actually is a great point. So unfortunately, we can't. Medicare wants to see, are you changing physician behavior? That's what they're most concerned about. What we're doing on top of that is where appropriate and where it doesn't totally disrupt the practices, collecting efficacy, whether it's something as simple as a CGI, radiological assessment of CGI, Or if you already have something, I know some practices I talked about earlier, everybody's assessed in PQ every time they show up. If that data is already there, you want to leverage that. And in those cases, there would probably be individual sub-studies for that site or a collection of sites that have similar efficacy. So if I was a perfect world, everyone would have nice, robust assessments at every time point. It's already in the EHR. Nothing has to happen different. We can just say, okay, what happened after the test? Did people get better? And can we put a real strong data point on it?
And some drugs have to.
Well, certainly we'd love to leverage that where it exists. Any other questions before we close this session? Awesome. Well, thank you all for joining today. Thank you.
I appreciate the great questions. So I thought the discussion was awesome. I appreciate that.
Great ideas out of this group. I mean, it's really clear we've got people who are already really thinking about these issues. I want to invite you back at 1:30. We're going to be reconvening here. I've got a speaker coming in. No relation to Tim Ramsey, Drew Ramsey. Drew is a psychiatrist from Columbia in New York and sort of affectionately known as the Kale Doctor. He is really one of the foremost thinkers nationally on the impact of nutrition on mental health, which is something, at least in my experience, we frankly don't think a lot about as an industry. We don't typically ask questions about that or think about how food plays a role in recovery. My personal belief is this is going to be one of the big areas where we're going to be changing our mind and understanding new things over the next decade. So really encourage you to come back and engage in that conversation as well. So thanks for joining.